Hello everyone. Today I shall describe in brief the evidence-based medicine. This is part of the Pharmacology Competency 1.2, which also includes therapeutic drug monitoring, which shall be discussed later. Now, evidence-based medicine is an important gain today because there is a pragmatic shift in the practice of medicine from experience-based to evidence-based. We need to have evidence for efficacy, safety, comparative efficacy, and cost effectiveness. It is defined as a process of systematically reviewing, appraising, and using clinical research findings to deliver optimum clinical care to patients. EBM implies that medical decisions, guidelines, and policies are based on currently best evidence about the effect of different forms of treatment and different forms. Why it is so important to learn about evidence-based medicine and practice EBM? EBM is an important tool for social justice, equitable care, similar standard treatment for all patients. It helps in developing standard treatment guidelines. It also helps in developing health policy documents. EBM follows the principles of bioethics such as autonomy, that is patient's involvement, justice, equitable justice, maleficence, beneficence, and non-maleficence. It promotes rational use of medicine and also provides uniform standard of care, so it has educational values. There are three key components of EBM: clinical expertise, the best research evidence available, and patient's values. And that will, when they are integrated, that becomes the evidence-based medicine. And this integration is very important, and we shall see in the practice of the EBM. Now, clinical experience also is important, and we have seen clearly during COVID-19 infection because not much evidence was available. It was a new disease. Therefore, decision makers looked at the knowledge along with the best evidence collected from time to time from controlled studies and research during persistent infection. And this clinical experience and the results of these studies were then combined in formulating decision-making process. Thus, standard treatment guidelines were made by professional bodies for use in clinical practice at different levels, and therefore guideline directed per protocol treatment was uniform across all countries for COVID-19 infection. And it is true for all other diseases also. Even patient's engagement or involvement is very important. Informed and shared decision making is a part of EBM. Patient's knowledge of EBM is important because it enables patient to make more informed decisions about the disease and its management. Available best evidence also gives patients a more accurate perception of the risk, encourages appropriate selection of elective intervention, and participation in making healthcare decisions. This actually reduces burden on the healthcare profession and also rationalizes the treatment. Patients' engagement in decision-making process has an important role to play in finalizing the required intervention. Now, from where do we get the evidence? Evidence can be of low quality to very high quality. Editorials and expert opinions is the evidence based on opinions of a panel of experts. There can be preclinical studies which will provide some evidence of efficacy or safety or effectiveness. Case series and case reports can also be there. The case series are the descriptive studies on small patient groups, and case report is on the individual patient as a observational studies are many times. They can be cross-sectional studies, prospective cohort studies, retrospective cohort studies, or case control studies. We'll appreciate that each one has demerits. For example, case control studies, we use cases and controls to compare the insulting agent and outcome. These studies are easy to perform but lack randomization and have some bias. They provide correlation but not the. This is an example of case control. If there is are cases of ADR, we take controls without ADR and see whether they are exposed or not exposed. We can find out the relationship or a correlation. Cohort studies are the cohorts in clinical studies is a group of people with defined characteristics who are followed in order to determine the health related outcomes, say occurrence of ADR in a particular cohort. Prescription event monitoring is one of the. It is a cohort type of the study where we see what events occur in a given number of prescriptions. Framingham Her study and NCDS studies are other. Here, population is selected. Two cohorts are made. One is exposed, the second is unexposed, and then occurrence of the outcome or a disease is seen. Cohort studies have advantages. We can see rare uncommon ADRs and find out the causal relationship also, and also quantify the occurrence of the risk. Can also example multiple outcomes, but there are disadvantages also because large sample size and longer follow-up would be needed, and this will impose a selection bias. Prospective cohort studies are expensive to perform, and retrospective cohort studies may have so many factors which are not under or were not. Randomized clinical trials are the gold standard to find out the effectiveness of an intervention, and the components of a randomized clinical trial are randomization, that will reduce bias, increase equal opportunities of each group, case or control. Then blinding is done as an open label, double blind, single blind. Then criteria of inclusion and exclusion are prefixed. Sample size is calculated, not too less, not too more. And type of the trial is already preset as sequential, open label or crossover trial. So this of a meta-analysis is further improvisation, is a systematic statistics-based review of data that contrasts and combines results from different but related randomized controlled trials. It is done in an attempt to identify patterns, disagreements, and other relationships across multiple studies. It can provide a strong evidence because it supports a stronger conclusion than any individual randomized trial and may reduce the publication bias, although it may. Now, highest level of evidence, as I told you, is provided by meta-analysis, but carefully selected systematic reviews can also provide very good quality of evidence. That is, a specific type of literature review conducted methodologically and transparently to provide evidence. It saves time to review individual studies for a busy doctor. Only systemic review and meta-analysis would be much easier to identify the quality of evidence. Limitations of a meta-analysis are introduction of bias, inclusion, publication, methodological problems. They all have to be looked into by gradient expert committees. Currently, Meta-analysis provides the highest level of evidence for the practice of evidence-based. Now, we should understand two terms. What do we mean by level of evidence and what do we mean by grade of evidence? Now let us look at the level of evidence. Level means hierarchy of the certainty, that is quality of evidence, which is the best evidence available. For example, experimental studies, expert opinion, case series, case control, systemic reviews, individual cohort studies, systemic reviews of cohort studies, individual randomized controlled trial with narrow confidential interval without wide scatter, and systemic review of randomized controlled trial. That means that will also include meta-analysis. Systematic reviews and meta-analysis provide the highest degree of evidence or highest quality of evidence, and therefore they are still considered to be best for evidence. So what do we mean by grade? GRADE is an acronym for Grading of Recommendations, Assessment, Development and Evaluation. The grade system is a transparent framework for developing and presenting summaries of the evidence, various levels, and thus it provides a systematic approach for making clinical practice recommendations, that is, therapeutic guidelines or standard treatment guidelines. Grade system today is the most widely adopted tool for grading the quality of evidence of making recommendations. Grade provides degrees of certainty. Low. There are many ways of the grading. There are 4 or 6 grades. A 4-grade system will be termed as grade A, B, C, D. And grade A evidence is provided by meta-analysis, randomized controlled trials, because they are highly reliable. However, grades such as grade E or grade F will only include those based on clinical experience or animal studies. Therefore, the strength of evidence will be low. These two can be seen together, grades versus level. We'll see that level 2A and 2B, even 3A, can also be graded as B by expert group depending on the quality of the evidence the trials are providing. Grade C and D would always be low quality. Oxford Center for Evidence-Based Medicine uses 5 levels and 4 grades, but different type of bodies and government organizations which are involved in grading systems use different type of grading systems. Some of the examples I will give you how these grades of recommendations are used in making therapeutic decisions. For example, in WHO malaria guidelines, use of artemisinin based combination therapy in children, adult with uncomplicated falciparum malaria, they said there is a strong recommendation, means higher grade, high certainty value. That means level quality L1, 2 and strong recommendation means grade A. Whereas same WHO for parental alternatives to artesunate, when it is not available, they will show that artemether should be used in preference to quinine for treating children and adults with severe malaria. But here conditional recommendation is there because there is low level of evidence, that is low certainty evidence. Another example is use of the anti-malarial drugs in pregnancy. Pregnant women with uncomplicated falciparum malaria should be treated with artemether lumefantrine during first trimester. Although certain books describe it to be not safe, but still WHO recently has given a strong recommendation, although at a low certainty level, to use this. Another example is American Diabetic Association recently have given guidelines for the treatment of diabetes mellitus type 1 and type 2. I have taken some excerpts from the type 2 diabetic section, and they use grade of recommendation as A, B, C, not D, and directly E. And the interventions are graded accordingly. For example, ADA gives grade B for an intervention that is in adults with type 2 diabetes and advanced chronic kidney disease with low GFR. Use of glutides, semaglutide for example, which is GLP-1 receptor agonist, is preferred for glycemic management due to lower risk of hypoglycemia and cardiovascular event reduction. This is in comparison to use of sulfonylureas. Now, but the evidence available is such that only grade B is. So what is the ultimate use is use of this evidence to formulate policies and treatments, and of course treatment guidelines also. Five-step model of practice of evidence-based medicine at individual level is defining a clinically relevant question. For example, what are the treatment options for a given disease? Then searching for the best evidence to support step 1. Then assessing the quality of evidence to ensure that quality and reliability are high for a selected option, and then acting on the evidence to form a clinical decision involving patient. That is important. That means now we are integrating the appraisal or evaluation. So three components are now integrated, and finally a joint decision is taken for the final treatment. So these 5 steps will explain how evidence medicine is practiced. So from where do we get the information on the evidence? Clinical trial registry and Cochrane registry. They are the two very important sources of updated sources of today. And best reliable online source to collect evidence is Cochrane collaboration and Cochrane. Cochrane collaboration is the international not-for-profit independent organization dedicated to making up-to-date accurate information about healthcare interventions and are readily available on its websites. It produces and disseminates systemic reviews of healthcare intervention and promotes the search for evidence in the form of clinical trials and other studies. Cochrane Library today have large number of evidence-based medicine database. Cochrane database for systemic reviews, abstracts for review effects, central registry for controlled trials, database for methodological reviews, and registry, and also health technology assessment database, NHS economic evaluation database also. At its core is the collection of Cochrane reviews, a database of systematic reviews and meta-analysis which summarize and interpret the results of a high-quality medical. This can easily be accessed through internet. Other references I have also included, and this completes with the evidence-based medicine. Thank you.